Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 46th episode of Optometry series. Thank you so much for your continuous support towards Optometry series. And as you all know, so we are doing the back to basics parts now, and today is the part 4. And today we're going to discuss about all from refraction to prescription. Basically, we're going to discuss more about the guidelines of prescription, and I'm very happy to welcome my team member, Ms. Meenakshi. Thank you so much for joining with us, Meenakshi. And Anshana was not able to join us now. She'll be joining in a few minutes. And one more thing, the planned moderator, Ms. Anuja ma'am, was not able to join us today due to unavailable situations. And Ms. Meenakshi has accepted, nicely and sweetly accepted a request to be the moderator. So thank you once again for that, Meenakshi. So we like to know more about Meenakshi. I request Saara to please introduce her today's moderator and the presenter. Saara can start your MC work. We would like to know more about the today's moderator. I request Saara to please add on the details about the moderator.
Good evening, everyone. I'm Saara, a first-year Bachelor of Optometry student at Dr. Agarwal's Institute of Optometry. I'm very happy and honored to welcome our moderator, Meenakshi N ma'am. Ma'am has completed her undergraduate studies at the SRM University and post-graduation at Vasan Institute of Ophthalmology and Research. Currently, ma'am serves as a senior assistant professor at Dr. Agarwal's Institute of Optometry, where she also holds the roles of clinical in charge and fellowship program coordinator. In addition, she is currently pursuing her PhD in binocular vision at SRM University. Thank you so much for accepting to moderate today's session, ma'am. Our presenter for today is Ms. Prathiksha S, a third-year Bachelor of Optometry student and a technical member of Optometry series at Dr. Agarwal's Institute of Optometry. Ms. Prathiksha, please start your presentation.
Thank you, Saara. Today's topic is about back to basics, refraction to prescription part 4. Introduction. Refractive errors are the leading cause of visual impairment globally. Myopia prevalence is expected to increase from 22% in 2000 to 52% by 2050. Many cases of refractive error remain undiagnosed and untreated, especially in resource settings. This significantly influences educational performance, workshop production, productivity, and overall quality of life. Early correction is crucial to avoid complications such as amblyopia, particularly in children. Technoscopy refraction. Technoscopy involves projecting light into the eye to observe retinal reflexes and evaluate the refractive status. This is the technoscopy reflects tightly and clearly how it will be seen. And with different types of flow, it is represented in the left side. Types of retinoscopy, static retinoscopy. Performed with relaxed accommodation with or without cycloplegic agent. Cycloplegic retinoscopy uses cycloplegic agent to paralyze accommodation, providing precise results in children and young adults. Non-cycloplegic retinoscopy performed without pharmacological agent. Dynamic retinoscopy evaluates active accommodation without cycloplegia. It is an accurate objective measurement used to evaluate the optical state of eye. Ametropic reflex, it will be with or against, and for if it is neutral point, it will be seen in the pupillary area. Subjective refraction, the detailed explanation is given in the episode 37. For more information regarding refraction, you can go and refer episode 37. And we'll proceed with the prescribing guidelines. For myopia, prescribe for functional improvement. For hyperopia, evaluate based on age, symptoms, and adaptation needs. For astigmatism, precise correction essential to avoid discomfort. The American Academy of Ophthalmology provides guidelines for prescribing eyeglasses for young children to ensure proper vision development. So guidelines for prescribing eyeglasses for young children, which is given by AAO for myopia. The conditions are isometropia and anisometropia. For isometropia myopia, the age of 0 to 1 year will start recording if go diopters more than or equal to -5. At age 1 to 4 years will start prescribing if it is more than or equal to -4. And if it is 2 to 3 years, we start prescribing if it is more than or equal to -3. And for anisotropia, where there is different power in it, right? We start prescribing to 1 year if it is more than or equal to -3.5 diopters. At age 1 to 4 years, we'll start prescribing if it's more than or equal to -2.5 diopter. At the age of 2 to 3 years, we'll start prescribing more than or equal to -2 diopters. Criteria to prescribe: minimum minus for maximum visual acuity. In case of low myopia, perform cycloplegic refraction. Add small minus power if there is ISO deviation or convergence insufficiency to aid convergence. Prescribe glasses once the child reaches school age for low myopia, typically if it is less than -2 diopter. In high myopia, prescribe full cycloplegic refraction. When to refer: moderate to high myopia, myopic changes in retina, retinal detachment with high myopia, large exodeviation. Unilateral myopia, prescribe if vision is compromised, myopia more than 3 diopters in children. Management: best option will be contact lenses to prevent anisoconia. Alternative, spectacles, eye intact lenses if myopia is more than 4 diopters. Anisometropia or antimetropia, perform cycloplegic refraction to confirm refractive error to eliminate the effects of accommodation. For difference which is more than 2 diopter between both eyes, check for diplopia, follow up for asthenopic symptom. Prescribe contact lenses to prevent anisoconia. Overcorrected myope. Differentiate overcorrection and pseudomyopia. Current glasses show more minus than manifest refraction, overcorrection of myopia. Manifest refraction shows more minus than cycloplegic, pseudomyopia, which is ciliary spasm. Adults pre-presbyopia. During late 30s, accommodation start decreasing. For myopia, minus lenses act as a stimulus to accommodation. Management will be removing glasses for reading, minimum minus for best corrected visual acuity. Suggest bringing glasses lower down on noses to increase effective power. Presbyopia management will be to put a bifocal, bring glasses lower down on nose to decrease effective power. Remove glasses and keep reading material within 4 point. Use contact lenses for distance and reading glasses for near and bifocals. Case exam. 8-year-old child complains of blood vision for distance since 3 months. Her parents have noticed squinting and rubbing of eyes very frequently. The parents have observed frequent squinting and eye rubbing. Additionally, the child has struggled to copy notes from the board, often making several mistakes. Her birth history is full-term delivery, no history of prematurity or neonatal complications. Birth weight was 3.2 kg, no history of retinopathy of prematurity or normal neonatal ocular issues. No history of glasses, surgeries, or trauma. Family history, both parents had significant refractive error. General health was normal. Examination. Visual acuity unaided on right eye is 6 by 36, with pinhole it is 6 by 12, and left eye 5 by 60 with pinhole 6 by 36. Her near vision was N6. Cover test, no manifest strabismus, but mild intermediate exophoria at distance and near. Axial length for right eye is 24.87 mm and left eye 24.66 mm. All other findings were normal. Retinoscopy, dry retinoscopy without cycloplegia. In right eye, it was 2.2 minus 2.25 ds with minus 2.5 dc across 80. And left eye, it is minus 4 ds with minus 0.5 dc across 100. Wet retinoscopy with cycloplegia. Right eye, it is minus 3 ds with minus 0.5 dc across 80. Left eye, it is minus 5 ds with minus 0.5 dc across 100. Management. Glasses were the choice of prescription by informant. Review 6 months. Advices. Myopia interventions were explained. Risk of pathological myopia is educated as father has history of high myopia. Discussion. The need for further encouragement into myopia control strategy was clearly indicated by both the pattern of progression and the parental risk factor. Hyperopia, the guidelines of prescribing high glasses for young children, which is again given by AAO. The conditions are isometropia and anisometropia. For isometropia, hyperopia with no manifest deviation with the age of 0 to 1 year will start prescribing if it is more than or equal to plus 6 diopter. And for the age of 1 to 3 year, will prescribe if it is more than or equal to plus 5 diopter. And age of 2 to 3, it is more than or equal to plus 4.5 diopter. Hyperopia with esotropia, full cycloplegic refraction will be done for the age of 0 to 1 year. And the age of 1 to 2 year, full cycloplegic refraction. Age of 2 to 3 years, more than or equal to 1.5. Astigmatism of 0 to 1 year will start prescribing if it is more than or equal to 3 diopter, and age of 1 to 2 year, it is more than or equal to 2.5 diopter. And with the age of 2 to 3 years, will start prescribing if it is more than 2 diopter. Anisometropia. Hyperopia will start prescribing if it is more than or equal to plus 2.5 diopter with the age of 0 to 1 year. And in the age of 1 to 2 year, if it is more than or equal to plus 2 diopter. And age of 2 to 3, it is more than or equal to 1.5 diopter. And astigmatism, more than or equal to 2.5 diopters in the age of 0 to 1 year, more than or equal to 2 diopters in the age of 1 to 2 years, and again more than or equal to 2 diopters in the age of 2 to 3 years. Criteria to prescribe lenses: patient presence with decreased visual acuity, any history of headache, eye strain during prolonged near works, deviation. Additionally, when the patient has difficulty with near vision, struggling to focus on close objects. When to refer: large angle deviation, limitation of eye movement, decreased visual acuity even with optimal corrective lenses, any abnormal face turn or head posture. Hyperopia, first time wearer, cycloplegia refraction is indicated based on age. If it is less than 5 years with deviation, full cycloplegic refraction will be done. If it is less than 5 years, again, normal visual acuity, no glasses, frequent follow-ups. 6 to 20 years, maximum plus for maximum visual acuity. Correlate refractive error with visual acuity. Adults pre-presbyopia age, ask the patient about any symptoms related to near vision. Perform dynamic retinoscopy to detect any accommodative lag. If any accommodative lag is present, avoid prescribing near addition. Conduct home atropine refraction to identify any latent hyperopia. Push the maximum plus prescription to achieve the best possible visual acuity. Use the Boris delayed test to determine the maximum plus that can be prescribed. Rule out accommodative insufficiency as the cause of symptoms. Presbyopia. Working distance and visual tasks are the primary important. Rule of thumbs to prescribe AD in presbyopes are Morgan's value, Hofstadter's formula, RAF ruler, AH divided by 10 minus 3. And another rule will be measure the accommodative amplitude and place 1/3 in reserve for the patient's working distance. Spectacle options will be bifocals, progressives, new wearer, explain them about the adaptation period, explain about magnification, use of bifocals while traveling or using strays. Unilateral hyperope, correlate refractive error with vision and age, look for ISO deviation, give maximum plus for maximum visual acuity. In children less than 8 years, perform cycloplegic refraction, important to find any latent hyperopia to prevent amblyopia. Prescribing less than 7 years of age, prescribe maximum plus. If vision does not improve, check for amblyopia and advise patching therapy. Unilateral hyperopia. If difference between both eyes, look for compliance of diplopia. Perform sensory evaluation. If the diopter is more than 2, advise contact lenses. Case example. The mother of a 7-year-old girl felt that her daughter sat too close to the television and she is not seeing TV from the far distance since few weeks. External and internal ocular health was within normal limits. Examination, refraction. Right eye is plus 6.25 DAs with minus 1 DC across 25 and the visual acuity is 6 by 60. Left eye plus 5.75 DAs with minus 2 DC across 5. It is 6 by 36. There was a combinant 5 prism esophoria at 6 meter and 40 centimeter. Stereopsis was 100 seconds and 40 centimeter with Randolph circle. There was no suppression. Fixation was central with both eyes. Management. Diagnosis is refractive amblyopia. The cycloplegic refraction findings was and the patient was instructed to return for re-evaluation in 1 month. Review of 1 month. Aided visual acuity was right eye 6 by 18, left eye 6 by 18 plus. Both eyes is 6 by 12. Over the next 3 years, the patient's acuity gradually improved to 6 by 9 with only small changes in refractive correction. Astigmatism, guidelines of prescribing high glasses for young children. Again, isometropia and anisometropia the condition. And will start prescribing for 0 to 1 year of age, more than or equal to 3 diopters. And the age of 1 to 2 years, it is more than or equal to 2.5 diopter. And the age of 2 to 3 years, it is more than 2 diopter. And anisometropia, astigmatism, more than or equal to 2.5 diopters for the age of 0 to 1 and more than or equal to 2 diopters for the age of 1 to 2 years, more than or equal to 2 diopters again for the age of 2 to 3 years. Criteria to prescribe. For new wearers, prescribe the minimum cylinder needed to achieve maximum visual acuity. Assess the degree of visual impairment. Monitor for asthenopic eye strain. Observe if the patient is squeezing their eyes to compensate for visual discomfort. In children, provide full correction to prevent the development of meridional astigmatism. When to prescribe? Symptomatic, like eye strain, rubbing of eyes. Vision decreased to even 6 by 9. Based on age, if astigmatism is present, up to 2 years, 3 diopter or more. 2 to 6 years, 2 diopter or more than 6 years, 1 diopter or more. When to refer? Indications for referral is corneal and lens abnormalities. Changes in cylindrical power and axis. Causes with age, with the rule, against the rule. Change in refractive index of the lens or cataracteous changes and diabetes. If there is change in cylindrical and axis, cylinder and axis, do JCC refinement, perform keratometry and confirm cylinder power and axis. If changes is more than 1 diopter, prescribe only after difference or more, correlate refractive error and visual acuity, For high refractive error of more than 2 diopter cylinder, keratometry is necessity for confirmation. Confirm changes in cylindrical power and axis. Even 5-degree change is significant. Management spectacle need more adaptation time. Uneven size effects because of meridional anisoconia due to different power in different meridians. Spectacle design, smaller eyeglass sizes, reduce peripheral problem, shorter vertex distance, minus cylinder grinding. Visual axis aligns with optical center. In case of bifocal, the sags should be high. Post-refractive surgery patient, change in corneal curvature post-surgery, perform refraction only after cornea has healed. Otherwise, explain the need of temporary correction. Perform keratometry, confirm magnitude of cylinder power and axis. Topography is a better option for accurate results. Compare pre and post-operative keratometry value. Prescribing post-refractive surgery, best options is contact lenses as cylinder is induced due to corneal surface irregularity, RGP lenses, back surface torics. If contact lens not possible, base refraction on keratometry reading. Use pre-op keratometry reading as a baseline if post-op readings beyond range of keratometer, Myers or distorted. Anisometropia. For difference of more than 1.5 diopter between both eye, contact lens is the best option. Possibility of meridional amblyopia due to meridional anisoconia. Meridional amblyopia generally not manifest on Watford dot test, may causes decreased vision that does not improve with lenses. Other tips, in case of pterygium, mostly high plus with irregular astigmatism. And in case of keratoconus, high scissoring reflex correlate with keratometry or topography. Aphakia, absence of crystalline lenses. Causes will be surgery, trauma, congenital anomalies, management of high myopia. Criteria to prescribe to increase the visual acuity. Any previous patching advice to continue the same. Correction, most common will be convex lenses of 10 diopter or more. In case of high myopia with clear lens extraction, low minus or low plus. Advantages of high plus, high magnification. Disadvantages of high plus, high magnification up to 30%. Jump effect, objects appear closer than normal. Jack in the box phenomenon. Peripherally invisible objects suddenly appear on shifting gaze. Pincushion distortion, images appear curved inward, decreased field of view, and poor cosmicity. Unilateral aphakia, contact lenses reduce spectacle magnification, jack in the box phenomenon, distortion. Contact lens also provide better field of view, cosmesis. For an aphakia, spectacle induced magnification is 33.6%. Contact lens induced magnification is 8.9%. Pediatric aphakia, unilateral. Better use contact lenses, avoid anisoconia and anisometropia. Occlusion therapy, most of waking hours. Bilateral, infants can use contact lenses or glasses. Preschool use contact lenses. Contact lens provide better field of view and overcome the disadvantages of spectacle. Infants add +3 for near to distance correction. In preschool, bifocals. Approaches to screening and referral. Direct screening in schools ensure high proportion of children are screened with monitoring of false negative by high health team. At local high care facility, integrated approach reduces program cost, promote community ownership and enhance sustainability. Screening at public facility possesses wider reach and ensure early detection of refractive error. Referral criteria, visual acuity less than 6 by 60 in either eye, even if correctable. Any child with strabismus, no improvement to normal visual acuity 6 by 9 with refraction. Refractive error requiring cycloplegic refraction. Ocular health issues, for example, corneal opacity, abnormal pupil, conjunctivitis, Biddot spots. Cycloplegia indicated for uncooperative children, visual acuity not improving with refraction, media opacity, strabismus, and suspected amblyopia, requires training professionals and parental consent. Guideline. Provision of quality spectacle can improve a child's vision, reduce discomfort, and even lead to better educational outcome. For some studies showed that spectacle wear is associated with poorer uncorrected visual acuity and higher levels of refractive error. So prescription of spectacles should be made only when there is a significant improvement in visual acuity. So these are the conditions: myopia, hyperopia, astigmatism, and anisometropia. For myopia, improvement of visual acuity by 2 or more logmark or Snellen line. Hyperopia, improvement of visual acuity by 2 or more logmark or Snellen line. Presence of amblyopia at child's age suggests the amblyopia in potentially treatable. Esotropia or Lodge esophoria. Astigmatism, improvement of visual acuity by 2 or more logmark or Snellen line. Presence of amblyopia at the child's age suggests the amblyopia is potentially treatable. Noticeably improved eye comfort. For anisometropia, significant anisometropia more than or equal to 2 diopter and one or more of the following correctly balanced lenses improved vision of most affected eye by 2 or more logmark Snellen visual acuity lines and more noticeably improved eye comfort. Presence of amblyopia and the child's eye suggests amblyopia is potentially treatable. These are the references. Thank you.
Thank you so much, Prathiksha. That was a very detailed presentation. You can unshare the screen. Thank you so much.
Yes, ma'am.
Yes, so now I request the moderator, Ms. Meenakshi, to add her valuable points.
Thank you so much, Pumati. I guess I'm audible, right?
Yeah, you're audible, Meenakshi. Yes.
Prathiksha, it was a very nice presentation. You covered major aspects of all the prescribing guidelines, be it for myopia, hyperopia, astigmatism, also for aphakia. All those criteria plays a major role before the ophthalmologist or the optams dispense the spectacles. So, as she covered the major points, I would like to emphasize on what is the need for knowing the prescribing guidelines. When we are talking about prescribing guidelines, refractive error, on the other hand, is booming as a leading cause for global burden. Those global burden doesn't only impact the individual as such, the individual's education, productivity, and quality of life altogether is getting affected in case of refractive errors. And refractive error, particularly myopia, which has shown an leading effect of 52 percentage by 2050. That is, they say that by 2050, 52% of global population would become myopic. This particular rise actually uh, plays a major role for us to address the particular condition called refractive error. Talking about retinoscopy, it is not just about identifying refractive errors. It is equally important to understand when to prescribe and when not to prescribe, because that plays a major role in development of visual conditions and ocular health for a particular child. These guidelines become indispensable when we think about a natural process called emetropization. The emetropization process is a natural process which occurs from the child at birth since the age of 6 to 8 years. During this particular time, the eye at birth will actually be hyperopic because of the shorter axial length and the flatter corneal curvatures. As the process of emetropization occurs, the child's eye will elongate and the curvatural changes will happen so that the eye becomes emetropic. These parameters actually should be given an importance before prescribing the errors for the particular child. Because when we prescribe incorrectly or when we give an inappropriate prescriptions, that can be an hindrance for the natural growth of the eyeball. That can lead to any long-term visual challenges for the particular child. Furthermore, when we address something about emetropization, also there is another end to look for is a birth history. A child who is having a preterm birth or any problems during the delivery, those things has to be addressed, because always the prematurity or preterm birth is associated with the myopic shift. Understanding those conditions also plays a major role when to prescribe and when not to prescribe. Along with the prematurity, low birth weight, retinopathy, and any pathological conditions in the eye or neonatal complications should be addressed before undergoing these prescribing guidelines, because this can influence the refractive outcomes or the ocular long-term ocular health of a particular child. Clinical guidelines where it is necessary, these complexities are being addressed. That is when the importance of systemic health, family history of any refractive errors are even considered while doing the prescribing guidelines. Family history of refractive error, example myopia. When both the parents are becoming a myopic, both the parents are having a myopic error, there's high chances that the child will become myopia. As she showed in a case, a child who is having a significant anisometropic error in the presentation, they also measured something called axial length. The measurement of axial length plays a vital role where we can monitor the elongation of the eyeball and we can predict this could be the changes in next 2 or 3 years of a child. So accordingly, interventions can be managed. Myopia, we do have many myopic strategies, myopia control strategies that has to be educated and it has to be managed for the child to prevent pathological myopia. In case of hyperopia, ESO deviation is said to be common. So addressing ESO deviation, astronomic symptoms before prescribing also plays a major role. In anisometropic conditions, risk of amblyopia has to be educated, plus prescribing intervention, be it spectacle or contact lenses, the effect of anisoconia should be looked for and it also be educated to the parents. And the binocular vision needs should also be balanced. In these cases, actually comes under the clinical aspects of the child where the optons assess and they prescribe and they leave it. But on the other hand, we should also measure something called psychological aspects of our children. Poor compliance to the spectacles or hesitation to wearing the spectacles should also be addressed, because we just prescribe and it goes on like that, the child will finally not wear the spectacle at all. So addressing on the compliance of spectacles, why will the child not wear the spectacles later on? Or is there any social stigma that is affecting the child for not wearing the spectacles? Those things also should be looked for, and educating the parents accordingly for the spectacle prescription is equally necessary, because the child will not wear the spectacle for two reasons. One thing, the child will not see any improvement with the prescribed spectacles. There can be no change in the visual acuity, so that the child will not feel like wearing the spectacles. Second, any discomfort that is caused by wearing the spectacles. Because we know the weight of the spectacles will lie on the nose bridges and the temples. So for the child, the growth of the nose will also be a little on the underside. So, keeping that in mind, we should prescribe the spectacle in such a way that it is flexible, it is non-weight, and it should not cause any skin allergies. Dispensing the pediatric aspect alone is a huge chapter. I'm not getting into that. There is one more condition known as social stigma. That is booming with the spectacles, the child might undergo many negative impacts. They can be social uh, cosmoses, that is cosmetically unappealing for the kid, or they can be uh, teased, or child can go n number of harassments with the help of spectacle wear. Those things has to be educated in a positive way, and we should uh, educate the child as well as the parents along with the school communities that these things should not be given a negative side. This is equally important for the child's visual development. That is when these compliances can be overcome and the solutions can be made for the visual developments. So by combining the clinical expertise with the evidence-based guidelines, also having a proper interventions by providing public awareness or school awareness, local community awareness, educating parents as such, can help us together collectively correct the vision, and we can reduce the global burden to some extent. Educating communities for social stigmas alone is not necessary. We should also educate them to make the child or to understand what is the ocular health of the child. Example, if the child is sitting very close to the TV and watching the television, they should bring that issue to the ophthalmologist or any optometrist nearby. So addressing that can help us detect the refractive errors even more early, and to manage them will be easy in a larger perspective. So by addressing these challenges holistically through forming a guidelines, by framing some strategies, providing public health awareness, we can significantly enhance and manage refractive errors in a larger scale. This can contribute to the betterment of visual health outcomes worldwide, according to me. This would be my add-on points for the presentation. Any questions to be taken for?
Yes, no, Meenakshi, actually, there's no questions on the chat box. Actually, I wanted to tell you that the social stigma which you're talking about is one of the least spoken thing when we come out, when we talk about refraction and the prescription guidelines. It is one of the least spoken things. So, thank you so much for emphasizing on that particular point, because every other points, people they speak, okay. but this is one particular category that is least spoken. So thank you so much for that, actually. And thank you for moderating the today's session also. Thank you so much.
Actually, there is a guidelines formed by IAPH, PHB, where they talk only about the psychological and the social stigma for the child as such. They have come with many solutions for each kind of social stigmas where the child undergoes in day-to-day life. I would like to share the screen alone for just 1 minute.
Sure,
With that,
sure.
I'll end my talk. Is my screen visible?
Yes, Meenakshi, it's visible.
Just a minute. So IAPB has shared us these guidelines for understanding what is the main reason for non-compliance and what could be the possible solutions to improve the compliance from the child. I guess this addresses all the social stigmas which the child faces in and out of the school life.
Yes, of course. So yes, integration of high health in school curriculum. It is also, we need to really think a lot about it. Yeah, we are speaking about that, but more emphasis is not coming on this particular part, is what my opinion is. So
Yeah.
for sure, in few years we'll get to this point also, where we'll keep doing awareness not only on eradicating the preventable blindness with refractive error, but also on getting how the social stigma can be eradicated. So we'll really talk
Yes.
about this. So we can actually take this as one of the topic also in our future Optometry series episode. We'll consider this for sure, Meenakshi. Thank you so much. Yes.
Thank you so much, Kaumati.
So with this, dear audience, thank you all so much for your continuous support towards Optometry series. We're winding up with today's episode with this particular point. If you like this video, give a thumbs up and share with your friends. We'll meet you all in the very next episode. Thank you so much. Thank you all.